Hello, everyone, and thank you for joining today's webinar, the ASPIRE Healthcare Toolkit, Improving Healthcare for Autistic Adults. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. To the right of your screen is a control panel, and as an attendee, you have the option of listening in using your computer speaker system or your telephone. To switch between the two, just select phone call in the audio pane and the follow-up dial-in instructions will be displayed. If you're having any trouble hearing me, please send a message through the questions pane and I will assist you. Now for today's session, we've also shared some materials located in the handout panel. You can download these materials at any time. At the end of today's event, you will receive a certificate of attendance via email. Since your mic is muted by default, you can submit your questions to today's presenter by typing them into the questions pane at any time. We will hold off answering any questions until the end of the presentation. So since most of you are here now, let's get started. We're now going to begin the recorded portion of today's webinar. To those of you who joined us, good afternoon and welcome to today's webinar, the ASPIRE Healthcare Toolkit, Improving Healthcare for Autistic Adults. My name is Kat Hughes and I'm your host for today's event. It's great to have you all here today and have the distinct pleasure of introducing today's speaker, Dr. Christina Nicolaidis. Christina is a professor at the School of Social Work at Portland State University and an Adjunct Associate Professor at the Department of Medicine at Oregon Health and Science University. As a general internist and health services researcher, Dr. Nicolaidis uses preparatory research to improve the health and healthcare of marginalized populations. The majority of her current projects focus on autism in adulthood. She is the co-founder and co-director of the Academic Autism Spectrum Partnership in Research and Education, ASPIRE, an international academic community partnership that uses community-based preparatory research to address the priorities of autistic adults. So without further ado, I'll turn it over to Dr. Nicolaidis. Take it away.
Great, hello, thank you so much for having me here. There we go. Oops, I forget about the delay, I apologize. So yeah, anybody who's been awake in the last few decades has definitely heard of autism. And it seems like any place you look these days, especially in April, there's messages around autism and particularly around autistic children. However, autism is not just a childhood condition, and autistic kids grow up. They grow up to be autistic adults. And I think many of us, especially those of us who are, parents of children that were diagnosed in the late 1990s or early 2000s, are realizing that it's really time to transition to adulthood, including adult healthcare. I also have to say it's also time to transition to research that's with and for autistic adults, because that often takes a different frame of mind than doing research on children. So a few notes before we get started. I have learned from my autistic colleagues to think about autism using a neurodiversity paradigm. That's basically just having respect for all forms of diversity, including diversity in how our brains work. I also tend to use a social model of disability, which really means that I situate the disability as in what the majority does versus what a minority does, as opposed to as a failing of an individual person. I'm not going to talk about that today, but that does very much influence how I approach healthcare and how I approach my research. You'll notice perhaps that I've been already using terms such as autistic adults or autistic children. Ideally, I'd much rather use person-centered language, which means that we use the language each individual person wishes to use to describe themselves. But obviously I can't do that when I'm doing a presentation. I use identity-first language when speaking about autistic adults to respect the very strong preferences of my community partners. I do often use person-first language when talking about people with intellectual disability, again, in respecting the preference of many of my community partners. And because there's such controversy, I'll alternate when talking about disability in general. So I'm going to be talking today about work done by ASPIRE, the Academic Autism Spectrum Partnership in Research and Education. My wonderful friend and colleague Dora Raymaker and I co-founded ASPIRE in 2006. And we've since put together a wonderful team of autistic adults, academics, family members, disability and health services providers, some of which with multiple roles, some of which without. But the basic idea is that we use community-based participatory research to include autistic adults as equal partners throughout all phases of our research projects. Excuse me, working from home. So we have a variety of projects going on. Today, I'm going to be mostly talking about the healthcare related projects. So you'll hear about some of our survey and qualitative work, and mostly you'll hear about the development and testing of our ASPIRE Healthcare Toolkit. We also have multiple other projects going on right now, our largest being around measuring adult outcomes, or measuring how effective services are for autistic adults. And then we've got projects around employment and burnout and a variety of mental health issues. So as I mentioned, we use an approach called community-based participatory research. The idea of community-based participatory research, or CBPR, is that we try to partner where academics and community members truly have an equal say in everything we do. It doesn't mean that we do the same things. And I don't expect my community partners to know how to run statistical analyses, and they don't expect me to know what it's like to live as an autistic person. However, we work together with the community in general, trying to keep the research respectful, accessible, and socially relevant, and the academic partners trying to make sure that the research is scientifically sound and academically relevant. That means that in each phase of the project, we learn from each other. We go back and forth. We figure out how are we going to do things to meet, again, those community priorities and those academic priorities. Individuals may be in both places. Again, I'm a parent. I sometimes speak from my lived experience. But the point is that we respect each other and we do work that has greater impact than if each of us were doing it alone. This ends up affecting everything. So you'll see as we go through that really my community partners, including, again, autistic adults, parents, service providers, help decide the choice of topic, the research questions, how we do our studies, our protocols, how we make our recruitment materials, our consent materials, and so forth. And you'll see they've had a large part in the development and testing of the ASPIRE Healthcare Toolkit. So I'd love to talk plenty about the collaboration side and the CBPR side of our partnership, because that's something I feel very strongly about, but we won't have time for that today. We do have a variety of guidelines we've created around the inclusion of autistic adults in research, around adapting survey instruments to be accessible, and around making websites as accessible as possible for autistic users. I'm happy to share more of those at another time. So we're here to talk about healthcare. And when I first started ASPIRE, we were interested in doing research that met the community's priorities. I'm also a healthcare provider and a health services researcher. So of course, we found a nice intersection there between a community priority, which was that people really felt they needed better healthcare, and the work that I'd been doing around healthcare access. However, at first, when we started saying, oh, we need to improve healthcare, we got a lot of people saying, but is there a problem? As a provider, I'd say, yeah, but we needed to look at that a little bit more carefully. So our very first study, quite a long time ago, was a survey to try to understand healthcare disparities. We compared autistic adults to non-autistic adults online to try to get a sense of what of what health care experiences people were having. And we found, not surprisingly, that autistic adults had greater unmet healthcare needs, including physical healthcare needs, mental healthcare needs, and prescription medication needs. We also found a greater use of emergency departments services, which to me as a primary care provider often feels like a failure of primary care. We also found lower use of preventive services such as pap smears and lower satisfaction with patient-provider communication and healthcare self-efficacy. Since then, many others have done research to, again, look at what the healthcare disparities are, and I'm just pointing to one of many studies that have confirmed and expanded that initial work, in this case by Lisa Crowan's group at Kaiser, that again found that autistic adults had greater healthcare utilization, but lower use of preventive services. In order to try to actually do anything about these, we have to think about, well, what's causing these disparities and what's causing the problems. So as part of our original work, we'd also looked at barriers to healthcare. And we found that that autistic adults experienced far greater numbers of barriers to healthcare, really across the map in terms of lots of different barriers, but some of the top barriers were fear or anxiety, not being able to process information fast enough in real time, facilities causing sensory issues, and lots of barriers around communicating with providers. So our next step was trying to better understand what actually was happening and what could be done about it. So we conducted a qualitative study where we interviewed autistic adults as well as supporters, family members, caregivers of autistic adults to really understand their healthcare experiences and what they thought would be better. And what we found was that it was really a complex interplay. Of course, there were patient-level factors, and anybody who knows anything about autism wouldn't be surprised that a patient's verbal communication skills, their sensory sensitivities, their challenges with body awareness, slow processing speed, etc., would affect their healthcare and their ability to obtain good healthcare. But it was hardly ever in isolation. It was always an interplay between these patient-level factors and provider-level factors. Knowledge about autism, a lot of incorrect assumptions, use of accessible language or lack thereof, openness to providing accommodations, and so forth. And then, of course, all of this is in our larger, very complicated health system has plenty of its own challenges. But we found again that it was that interplay that really ended up predicting the success of a healthcare interaction. I thought there were a few things that were particularly important. One was how often patients talked about sensory sensitivities. This is an example from one participant who said, "The lights in the office are very bright, and that is exacerbated by the white walls. Sometimes the waiting rooms are crowded, and I cannot filter out the background of people talking or shuffling magazines. I feel disoriented by being led down long hallways to different rooms. I'm not able to bring up my concerns because it's all that I can manage to figure out what the doctor is saying so I can respond to his questions. But he refills my meds as usual and I go on my way." Similarly, we heard lots about challenges with body awareness. For example, like when they ask if pain is shooting or stabbing or burning, it's like, I don't know, it just feels funny. Or the problem is, it is difficult for me to isolate specific sources of pain and identify duration and intensity. It's sort of like the equivalent of white noise. Unfortunately, we also heard lots and lots of comments around providers' incorrect assumptions in all directions. For example, I've used my AlphaSmart when my speech is too slow or difficult to understand for medical appointments. Some of the doctors have been really great, but others have acted really condescending when I use it, also immediately assuming I couldn't be alone, had to have my parents there too, so I try to go without even when my speech is in poorer shape. On the opposite side, usually when I demonstrate a large vocabulary or some fundamentals, my needs, especially around communication, are then ignored. My choice is then to pretend to be less intelligent and expect their infantilism, or to be confused, frustrated, and stressed out. We also heard that communication, and especially openness to accommodations, makes a really big difference. I prefer and find it easier to communicate in text, but with every doctor I speak to, they wave away the note card and look at me to ask the same question I've just answered and interpret my confusion as my being non-compliant with the medicine. I wish healthcare providers would read the notes I make for them. Or as a supporter said, but they talk to him in the same words that they'd use if they were talking to me. If they're going to talk to him, they know they need to say it how he can understand it. Finally, across the board, we heard a lot of frustrations around decreased patient autonomy, especially as people transition from a pediatric world to really being adults in the adult healthcare system. Just because I might need more information to understand things, it doesn't mean they can or should just talk to me like a child or leave me without knowledge of my own health. My body is my body, and my experiences and wishes about my body are mine to make. So again, not surprisingly, we heard lots and lots about providers' role in all this. And as a provider myself, I have to say I never in any of my health medical training, residency training, any place in my continuing medical educations had I really heard even a sentence about autism until I became interested in it, again, largely for personal reasons. We originally were, again, trying to figure out, well, what would PCPs, primary care providers, want from us, what would be helpful to them. So we'd sent out a little survey, and not a particularly representative sample, but so we sampled 129 primary care providers, and the vast majority readily admitted that they felt uncomfortable in their ability to provide quality care for adults on the spectrum. Even so, about 84% of them said they had no plans to seek additional training on autism. At the same time, almost all of them would accept an autistic adult in their practice. But again, very few would have the time to attend a continuing medical education. The thing we caught onto, though, is that almost all of them would search for information on the internet, and all of them said they would read a customized report about patients' need, and they would appreciate the effort. And that's kind of what helped us figure out, okay, and I can understand it. We have a lot to try to do. It might be that each of us might have 1 or 2 patients on our panels, but we definitely care about the patient. And we've taken an approach around a kind of need to know just-in-time approach to working with primary care providers, because most of us really do want to do our best with the patient in front of us, even if all the complexities of a difficult job might keep us from doing the trainings that we should be doing. We also did qualitative interviews with primary care providers to, again, get a better sense of what would be most helpful to them. Since then, others have found that it's not just a fluke that our providers said that they weren't comfortable. A large survey in the Kaiser system found that the vast majority of providers, including those in internal medicine, OBGYN, and mental health, rated their own knowledge about autism as poor or fair. And then more recently, even as baseline surveys from our current projects, we find that a very small proportion of providers say they feel confident in taking care of adult patients on the spectrum, with particularly low proportions feeling confident around identifying accommodations or making accommodations. And again, there's a lot of challenges. I'm an educator. I very much, I do a lot of education of providers to try to help them take better care of autistic adults, but at system level, it can be quite difficult. Currently, there's no current training requirements anywhere in the medical nursing school or residency accreditation programs. There's very crowded curricula and very little being done. There are a few model programs right now that are happening, that are promising, that need to be expanded. And as I said, whereas I definitely, again, offer and like to do continuing medical education for practicing providers, there's many competing priorities. And for any individual provider, there's often a very small number of patients on the spectrum. The other thing is where we are cohort-wise. Even though autism, I believe, has been there for all time that humans have been there, the huge increase in the in diagnoses of autism happened with the cohort of children that were diagnosed in the late 1990s and early 2000s. That cohort is now entering adulthood. That's why there's now suddenly all this attention to transition. But that cohort is also just that age is the age of people who tend not to get a lot of health care. As an internist, I can tell you most of my day is spent taking care of much older patients. I might get somebody in their 20s in my practice every once in a while. So it's not really on our radar yet. Even though there has been a large influx and a large transition, they're still at an age where most people don't tend to see the doctor a lot, thankfully, because they're healthy in those years. It's hard to focus a lot of attention on that very important age group. So, and then the final big challenge is that autism is a very heterogeneous condition. There's an adage of when you've met one autistic person, you've met one autistic person, and that's totally true. I do try to do a lot of trainings for providers, but ultimately it's very hard for me to say that, oh, you should do this or oh, you should do that, because different people will end up having very different needs, very different strengths, very different challenges when interacting with the healthcare system. So that's what brings us to our ASPIRE Healthcare Toolkit. That was, again, largely driven by the community quite a number of years ago. It was really this idea of trying to create a set of tools that would be helpful, both in empowering patients and their supporters to access healthcare and in empowering providers to do the right thing and to be able to offer the high quality care they wish to have. Oops. I'm just going to just offer a quote here. One of our early and very important community partners was Mel Baggs, who unfortunately passed away last year. But she often presented with me when I was speaking to providers, and as she said here to providers at the Society of General Internal Medicine, she says, remember that we're all human beings. We all deserve health care. Often we turn up with things that are more typical of people in countries without medicine because we get so much medical neglect. That's people with developmental disabilities in general, probably also psychiatric disabilities. Each of us is different. That's why we did the toolkit. The toolkit helps people talk about specific issues that are different for all of us. Every time I nearly die and survive, I know that means other people didn't survive. I wrote this so that more people will survive. So, as I mentioned, we developed the toolkit largely based on the prior survey and qualitative results I mentioned, and often also just our community partners' experiences. Community partners wrote, reviewed, or edited just about every single part of the toolkit. We then did a cognitive interviewing study with autistic adults, supporters, and primary care providers outside of our team, really to ensure that all of our materials were easy to read and understand and useful. And then we did some other additional reliability studies to make sure that, for example, the accommodation requests that people are making are stable over time. So this is the toolkit. It has two parts to it. There's a part for patients and supporters. And then there's also a separate part that's for healthcare providers. On the patient side, there's all sorts of information about finding providers, making appointments, preparing for a visit, during the visit, after the visit, and so forth. All of it is done in a question and answer format where you can look through the questions and get more detail. This has been done with great specificity to really meet our community partners' needs around how much information they would need. There's also a number of forms and worksheets. These are things that people can use to help really better advocate for themselves during in the healthcare system. There's a worksheet to help people make appointments. We found that especially adults that didn't have a lot of support from others had a hard time even getting in the door because making an appointment was such a barrier. So this helps people through that. There's a checklist of things that you might want to bring with you to a visit. And then there's a symptom worksheet, which I personally really love. This actually comes from what we teach medical students to ask in terms of how they take a history. And we found that by having that kind of framework of how I think about my symptoms, to have that in advance, people can collect their thoughts and put those together so they're not having to think about those things in real time. There's also an after the visit worksheet that helps people make sure that they've got everything they need before they leave a visit so that they can then follow up on their care and follow the recommendations and manage their health. There's also a whole host of information for providers, including tips for successful office visits, basic information about autism, and plenty of other resources. To focus for a minute on the centerpiece of the toolkit, which is our Autism Healthcare Accommodations Tool. Here, a patient or their supporter fills out a survey, and then the computer uses the answers to create a personalized and healthcare provider friendly report of accommodations. I'll tell you, when we were creating these tools, we thought the hard thing would be to come up with a survey that would be easy for people to understand and would cover everything. That went really smoothly. It took us umpteen versions of a report before we found something that was accessible to primary care providers who are very busy and who don't have time to read a lot of details. So we worked really hard with them to try to find something that they can really quickly get to the actionable items of things that that will really help them provide care. There are copies, by the way, of some sample reports on your handouts sheet. We have the survey itself is broken up into areas around how you communicate, communication suggestions, things that might help you before the visit, during the visit, after the visit, some information that might help your provider to know you, and then information about supporters. And the roles that you hope they can play when accessing healthcare. The AHAT itself, the survey itself uses software that has read out loud features for people who might have trouble reading. And we've worked again with our partners to try to make this as accessible as they can. You'll notice that for each one, we offer a variety of different potential accommodations, and we ask people to just pick a few of them to not overwhelm their providers. The AHET report itself, as I said, we have copies of them in the handouts. There's a cover letter, there's a main report, and then there's separate information for the office staff, and then a separate sheet with information about the supporters and how we can contact them. And again, we've worked to try to get lots of white space, clear, actionable things that providers can do to try to make visits run better. We tested the toolkit originally in, this is a pilot test. We did a pilot test using a mixed methods 1 month pre-post intervention study. We had about 170 autistic participants use the toolkit, and then we sent the reports to primary care providers, 41 of which we participated in our quick survey around how that went. Almost all participants found the toolkit and the tools easy to use, important, and useful. And again, this is just pre-post data, and this is just we didn't have a control group, but we did find that comparing surveys before they used the toolkit and a month afterwards, participants who used the toolkit had significant changes in the number of barriers to healthcare with fewer barriers to care. They had improvements in their healthcare self-efficacy, and they rated their patient, and those who had seen their provider during that month rated the communication with their provider higher. We also saw lots of strong kind of qualitative themes around why and how the toolkit was useful to them. People saying that it was really a means to clarify and communicate their needs. It often validated their experience and empowered them to better self-advocate for themselves. And then they felt more comfortable in being able to manage the system and to be able to prepare for visits. We did also have some nice concrete examples of how providers changed their behaviors because of the recommendations in the AHET reports. I have to say, as much as I find, that was very promising, we have had lots of challenges since then. We had another NIH grant to integrate the toolkit into 3 health systems, and we worked with clinics to try to find processes that would work for them to fit this into their clinic flows, and it was challenging. We meant to compare 6-month patient and provider outcomes from clinics that used the toolkit to those that didn't, but there were many, many system challenges, and I have to say that despite our great efforts, oftentimes the reports didn't really make it to providers at the time that they could really use them. Got lots of lessons learned and lots of things that I'd like to do differently. Ultimately, almost everybody who used the tools really found them useful, but there's many, many system level challenges to getting them actually to the right people at the right time in a way that works in our lovely and complicated healthcare system. At this point, what I'm finding most helpful is patients just simply literally bringing them to their provider, and that's where we've had by far the greatest success. We're continuing to work. The toolkit was initially made for the primary care system, but obviously that's not the only place that autistic adults get healthcare. We're currently working on a project understanding hospital experiences and trying to adapt the toolkit to hospital settings. And we have lots of work planned in the future. At this point, we just kind of wish that people would at least use the tools that are out there. They're free, they're publicly available. Please use them as they best work for you. We're working with Jeremy Parr and his collaborators in the UK, where we're combining our AHET tool with their annual autism check to use that throughout the national health system in the UK. And again, with appropriate resources, we'd certainly like to do more research and into how to make this actually feasible and workable within healthcare systems. So Some final thoughts. Again, not a big surprise, but autistic adults currently experience significant healthcare disparities. And I can tell you as a healthcare provider, it's challenging. It's challenging from all sides. Our adult healthcare system is currently just not equipped to manage autistic adults' needs. There's great gaps in provider knowledge and skills. There's many barriers to care, and ultimately successful interactions depend on addressing patient, provider, and healthcare systems. The ASPIRE Healthcare Toolkit, it may be a small drop in the bucket. Again, at this point, we only have preliminary data saying that it actually makes changes, but it is promising, and I still think it's an important step towards improving care. I'd love to work with others to try to make even greater changes to our health system. And we need solutions at all levels. In the meantime, I think many of us who actually still practice and work and live, and again, as a parent, as a provider, I need practical solutions, and it has been really wonderful hearing of many individuals who've found these tools to be helpful for them in their own attempts to get good quality healthcare. Wanted to thank our funders. Most of our fundings come from NIMH, but also plenty of others. And then of course and before I thank others, I wanted to just point to a number of resources. As I mentioned, the Healthcare Toolkit itself is available at autismandhealth.org. It's free, and we'd love for people to use it. A separate project that I haven't talked about today has been looking at pregnancy resources for autistic people and people with intellectual and developmental disabilities. Those are available at pregnancyandisability.org. And then for anyone who's interested in the collaboration side, the how we do participatory research, we have a collaboration toolkit on our website. And then finally, I'm going to just put in a whole plug. I hope it's not too self-serving, but I'm editor-in-chief of a new peer-reviewed journal called Autism in Adulthood. And we're really trying to focus the journal on the issues that matter most to improving the lives of autistic adults. We have autistic adults involved at all phases, from editorial board to reviewers to authors to readers. And the point of the journal is to highlight work that can have real practical value as we try to help autistic adults live the most fulfilling lives they possibly can. And I had a thank you slide. Did my thank you slide? Here we go. And again, and many thanks to our project team. This is a group effort at all levels, and certainly our many ASPIRE partners have had a huge role along the way. So I'll take some questions.
Wonderful presentation. Thank you so much. Our first question is, do you plan to validate this for LMICs?
LMICs, I'm sorry, I don't know what LMIC is.
Okay, well, we'll wait. Maybe they can do a follow-up for us on that one.
Sorry about that.
No worries. Let's see here. Have you seen people use these tools?
Yeah, very much so. So one of the lovely things that I just so appreciate is every once in a while I'll get these great little emails, or a tap at a when I meet somebody where people often come to me with great stories of how they've used the tools. A lot of it is just in preparing for visits. And that sounds like a small thing, but for people who have a condition or characteristics that make uncertainty so difficult, being able to prepare for a visit, being able to know to have got your thoughts together, to be ready for that visit makes a really, really big difference. I've also heard providers, actually colleagues of mine, come to me and say, oh, wow, I never really thought about these kind of very simple accommodations. Having them right there has made a big difference. And I've had patients also say that they were able to see that their provider made a big effort to, for example, write out an agenda or to give them multiple choice type questions when they were asking them questions, kind of simple things that don't take a lot of time. I myself practice, I was a primary care provider for a very long time, but now as my research has taken up a bigger part of my time, I've limited my clinical work to inpatient hospital settings. And even in the hospital setting, I've used the tools. I've used the tools both with individual patients who are autistic and actually also with other patients who have need for greater accommodations. Again, the tools aren't built for the hospital setting, but oftentimes just having things spelled out, having very concrete things that I can do differently or that the nurses can do differently or that my colleagues can do differently has made a really big difference in kind of the day-to-day care we can give in the hospital too.
Right, before I clarify the last question that came in, I just want to remind everyone you can still submit your questions through the questions pane. During the Q&A portion, we're going to answer general questions, so try to phrase your questions in a way that doesn't involve particular individuals. So to clarify the last question, do you plan on validating this for low, middle income countries?
Oh, yes, I would love to. Thank you, and I'm sorry for not getting that acronym. I would so love to. In fact, I was just having fantasies of trying to do a Fulbright someplace to do this in low and middle income countries. I think the challenges in low and middle income countries are in some ways similar, but in other ways quite different. And very, very interested in what this might look like outside of the US or the UK or the Australia or places where we're currently working. We did a roundtable last year about autism and adulthood in low and middle income countries for my journal, and that really was it was just a very good discussion, and B, it made me even more excited to potentially try to do this work outside of the US.
Right. The next question. Do you also have quantitative data which shows that the toolkit helps improve care for people on the spectrum?
Yeah, so the quantitative data we have so far is from that study that I mentioned. And again, caveat is this was a convenience sample and this was pre-post data. But as preliminary data, what we found was that we had, so quantitatively, we had decreases in the number of barriers to care. We had increases in patients' report of their self-efficacy, and we had increases in patients' report of their satisfaction with patient-provider communication. What I'm hoping to do is to do a larger randomized controlled trial using the toolkit where we can look at these types of healthcare outcomes, these types of patient-reported healthcare outcomes, but we can also look at healthcare utilization outcomes from medical records. Unfortunately, to do that, we have to first really make sure we understand how to get it used within healthcare systems. Because I said the data we have is from when patients brought it to their providers, and that worked very well. As I mentioned, we had some challenges in getting it to providers, and we're working those out. But once we can work those out, I do hope that we can get even better, or actually better effectiveness data. But our preliminary results is all we have right now. And we definitely need to do more research.
Right. This is a two-part question. What barriers did you encounter in trying to integrate these tools into health systems? And what ideas do you have for overcoming barriers?
Yeah, we had again some predictable barriers and some that were a little bit more surprising. I'd say the biggest things were actually getting the tools to the providers at the right time. I think a mistake we made was that we sent we sent providers reports out of context. They weren't tied to a particular visit. And I can understand now in retrospect, again, having been a primary care provider myself, that our inboxes are just filled with so much stuff. This report comes in that's not tied to a particular patient visit. And by the time we actually see the patient visit, it's out of sight, out of mind. And most providers we surveyed in these health systems really honestly don't remember ever receiving it. Or even having seen it. So I think one change we would make would be to actually tie the reports to a visit so that providers have a more actionable thing right then and there. The other thing was that we talked to clinics about how we should put these in the medical record and how we can find them the easiest. And I'd hoped to do like a little alert that pops up when you go into a patient's medical record, but all the clinics originally said that, oh no, we have too many alerts, we can't do this, everybody's got alert fatigue. So we came up with these pretty roundabout ways that ultimately, I think, again, people weren't able to find them. And interestingly, when we interviewed providers after the fact, they all recommended, oh, well, you should have an alert because that way I'll see it as soon as I go into the chart. So where now I said I would actually create alerts, even though there's alert fatigue and even though people get lots of these, I think having something actually pop up so that providers are seeing it makes a big difference. And again, I think where the difference was, and other things too, but I think there's a difference between our first study where participants chose to do this and chose to bring it to their provider versus our second study where we really tried to have this come from the healthcare system. And I think oftentimes it didn't get to the right people. And also some, especially some of the younger participants or the participants that don't have a lot of co-occurring health conditions, healthcare wasn't necessarily their first priority. So figuring out ways that we can, again, attach it to actual visits, get it to the providers, and make sure that patients get to use all the different tools, not just the report. Those are probably the things I'd work on first.
Wonderful. A lot of great questions coming in here. All right. Do you do studies of other aspects of autistic adults' lives or just healthcare?
Oh, lots. Healthcare is one portion. That's what we started with, partly because that's where my expertise was, but that was over 15 years ago. Right now we have several active projects going on. My wonderful co-director and colleague and friend, Dora Raymaker, started as my autistic community partner, and in the intervening 15 years, she has gotten her PhD, she has gotten her own NIH funding, and now we work together, and she leads projects around employment for autistic adults. I currently am leading a large project around how we measure life outcomes for autistic adults, in particular, how we can best evaluate services. So we're focusing on health outcomes, we're focusing on social outcomes, employment outcomes, quality of life, communication, other such things. We just came up with actually a list of 15 important topics to focus on for that project. And then we have projects, we have a new project starting up that my colleague Ann Kirby is going to be leading, that's going to be around suicide prevention. We just finished a project around autistic burnout, and we'll hopefully be continuing that in the future. We've got a new project that we're just well, we finished a project about pregnancy, and we've got a newer project around decision aids for around pregnancy. And then we've got some work around violence against people with developmental disabilities. But all of these things are very important, especially as we say, the employment and burnout and other things that make a real big difference to the autistic community.
All right. Is it difficult for you to find specialists, cardiologists, pulmonologists, et cetera, who are open to accepting patients with autism? As an internist in New Jersey, I'm trying to assemble a team of specialists who are open to learning how to best accommodate individuals with autism and I/DD.
Yeah, I hear you. I haven't found it very hard to find subspecialists or specialists who are interested, who are willing to accept a patient, but there's a difference in accepting a patient and in actually being able to understand enough about autism to make the right accommodations. And that's often a case-by-case basis. I do ask my patients to use the AHAT when they go to their providers. Again, it says primary care, but really the same issues can work for a specialist, and oftentimes that's at least something. And oftentimes it takes an extra phone call to a provider to try to, make sure that I'm kind of helping to navigate some of the autism specific issues. I'd love to see more specialists. I'd love to see more doctors of any type. Really kind of invest a little bit of time and energy in figuring out how to best accommodate and support autistic patients. And then there's a few here and there that are amazing. And sometimes because of a personal interest, sometimes because they just are really great doctors that listen to their patients.
This question kind of applies to that. So where can we write to you for collaboration?
My email is the best. My email is nicol22@pdx.edu. I think it's probably on some of the handouts, but if it isn't, I can type it into the chat maybe. Would that work? Let me see if I can type it into the chat. No, I can't.
Actually, I think I could do it for you.
Great.
Okay, to go to the entire audience?
Yeah, great.
Okay, there you go. Wonderful. Okay, so our next question is, how do I get involved in the study myself as an adult on the spectrum?
So probably the best thing is to either email again me, and we'll put you on our listservs, or to follow us on social media. We have a Facebook page and a Twitter feed that's for Aspire. We send out recruitment announcements whenever we have studies that are open to recruitment. Right now, this particular day, we don't have any studies that are open to that are recruiting participants, but again, we will in the near future. And then we only get, that's for being included as a participant in studies. We also again include autistic adults as team members. That we only bring new partners onto the team every few years when we have a new project starting. So that, because we try to make sure that people really stay with the entire project, and there's a lot of work that goes into really becoming a true team member. We will be having a new project. As I mentioned, we have a new project starting on suicide prevention, and my colleague, Dr. Kirby, will be looking for new community partners for that, with probably over the summer or in the fall is when we'd be looking for new partners for that project. But for normal studies, we would love to have people again join our listservs, and we'll send out announcements.
Right, looks like we have time for one more question. What can be done at the med school level to expose students to ASD from the outset?
Good question. So I would love to work more on, and again, exposing students from the very beginning. Each school has their own curriculum issues, and again, it's a very crowded curriculum. It's hard to get into the curriculum. For schools that are interested, then we have lots of ways, and I think it's particularly important that medical students really see healthcare and see their role by interacting with people, by interacting with autistic adults, by interacting with autistic adults across the entire spectrum. And I don't mean it as a linear spectrum, but there's so many different ways that autism can present. So I think having experiences where medical students can meet, interact with, talk with, communicate with autistic adults, many different types of autistic adults, I think is really important. And then certainly learning about autism, learning about neurodiversity, learning about disability in a way that respects patients and that listens to patients and that focuses on accommodations and supports. We've got, again, there are particular programs here and there that have a champion that has really been able to work it into the medical school curriculum. At a bigger level, I would really love accreditation bodies and at a national level to be saying, no, this has to be in the curriculum, and there has to be, whether it's autism by itself or developmental disabilities in general, that we really need to start building in some accountability at a high level that this is in fact part of what we need to be teaching medical students, because right now that isn't coming from the national organizations, and I'd love to see more pressure there. But again, if anyone is interested and has a medical school that would be willing, I'd be more than happy to offer materials, insights, etc. The coming up with things and coming up with curriculum isn't the hard part. It's really honestly getting it into medical school curricula that I found is the hardest thing.
Thank you so much, Dr. Nicolaidis. Do you have any closing statements before I do the final script?
I'll just say thank you very much for having me. It's always weird speaking out to the ether, so if anybody wants to contact me, please do. Look forward to hearing from you, and thanks again for having me here.
Wonderful. Thank you again. And thank you everyone for joining us today. Once you close out of today's event, you're going to receive an exit survey, and we would really appreciate it if you complete that and provide your feedback. Everyone will also receive a follow-up email with a link to today's video recording and materials within the week. On behalf of the Organization for Autism Research, thank you for joining us today, and have a great rest of your day.